Um, this is a talk on the anatomical variations of the extrahepatic biliary tract. There is obviously a great many variations of the intrahepatic biliary tract, which I'm not going to talk about. I've chosen to talk about the extrahepatic biliary tract because it's much more relevant to the general surgical aspect of the work, in particular in relation to the laparoscopic cholecystectomy. When we start doing a lap chole, most people expect an anatomical arrangement shown on the right side. As you can see here, most people expect the right and the left hepatic ducts join intrahepatic to become the common hepatic duct, and a long, nice cystic duct joining the common hepatic to form the supraduodenal aspect of the common bile duct. And of course, there is the retroduodenal as well as the pancreatic portion of the common bile duct. However, as I will show in a minute in the next few slides, there is a great many variation to this, and I have essentially divided them into three main subgroups. The first group of the variation is the point of the confluence of the left and the right hepatic duct. You can see in diagram A, this is one variation, which is, from a surgical point of view, not a bad one to have in relation to a laparoscopic cholecystectomy. The other variation in B is when the confluence is extrahepatic. Note that the left duct is often longer than the right. And of course, the one to be most wary of is variation C, where in this case we have a very low confluence, to the extent that in this occasion, the right duct actually opens at the base of the cystic duct. And you can see how this structure here, the right duct, for example, can be damaged if one is not careful in the callous triangle. So this was the hepatic duct confluence variations. The second one out of the three variations that I'm going to be talking about is the insertion of the cystic duct. And I've got some of the more common ones here. Essentially, they are kind of divided into ones which are run parallel. Sorry, I'll go back here. So there are ones which run parallel. The cystic duct runs parallel to the main duct system, such as A and, for that matter, F. There is another subgroup where the cystic duct actually opens on the other side of the main duct system in a spiral fashion, either anteriorly, as in B, or posteriorly, as in C. And lastly, the variation D and E, where you have rather very short cystic duct. Of these, probably the more dangerous ones from a surgical point of view I can think of is particularly the ones which run parallel and the short ones. But the ones that run parallel, they can, due to, for example, inflammatory condition, or if these structures are rather thin, they can actually appear to be one structure. So you can easily mistake the cystic duct and the common hepatic duct as one structure. And that, for example, happens in A and F. When the cystic duct is rather short, you can actually mistake the common bile duct for the cystic duct, because if you're grabbing the Hartmann's pouch and pulling it laterally, you can actually tent the main duct system, and the common bile duct then realigns in a kind of a funny angle in relation to the rest of the biliary system, in line with the gallbladder, and appears to be the cystic duct. And you can see how people can clip that and transect it. So these are some of the variations of the cystic duct. So the first one was the confluence of the left and the right ducts. This one is the cystic duct insertion. And lastly, we're going to talk about some of these accessory hepatic ducts. And you can see how, for example, in A, you have an accessory duct here. In B, here's another accessory duct. And in C, there's an accessory duct. It doesn't really matter where these ducts drain to. That's almost irrelevant. But you can see how damaging these accessory ducts probably most commonly can cause problems with bile leak postoperatively. And also, unlike what you see in these diagrams, remember, any of these accessory ducts can be fused with a cystic duct, or for that matter, with a medial border of an inflamed, fibrosed gallbladder. And it's very easily damaged. So these are some of the anomalies, and of course, when the anomalies are combined with inflammation, it becomes a particular problem for the surgeon. That's probably all I had to say for anatomical variations, which are most relevant in relation to the laparoscopic cholecystectomy. However, the knowledge is really not enough, and what you really need to develop is a sense of a healthy level of paranoia when it comes to laparoscopic cholecystectomy. But first of all, you need to see every laparoscopic cholecystectomy as a potential case that you're going to divide the bile duct. And so when you look at a list the day before, you don't see a lap chole, you see a division of a bile duct. And then you also intraoperatively, you get into this habit of actively questioning the nature of what appears to be the cystic duct and the artery. So the problem is that all these pictures that I showed you, the reality is a lot of them can actually appear to be that normal, expected arrangement. And you will only realize the mistake once it's been committed. So you really need to kind of verbalize your continuous sense of unease and get your surgical assistant even involved in that discussion. There is no such thing as a routine, easy operation, particularly when it comes to lap chole. And in fact, with experience, what you need to develop is this sense of the more routine and easy the operation appears to be, the more paranoid you should get. Because what appears to be easy might actually be a trap. So, and of course, this healthy level of paranoia, I would call it, would and should increase the more surgically experienced you get. That's the end of this talk. Thank you.